introduction. So first we have Tamika Wong. She's the Director of Neurosurgery Clinical Research at Lenox Hill. She received her bachelor's from the University of Florida with a major in psychology. And then she earned her MPH from NYU, so welcome. And then we have Sana Bokil. She's a clinical research project manager at Lenox Hill. She's experienced in radiotherapy, dosimetry, research, and clinical operations. She received her bachelor's and master's from Monash University. We have Faith Singh. She's a clinical research coordinator for the Department of Neurosurgery at Lenox Hill. She helped Lenox Hill coordinate their 2023 summer clinical research interns, and she received her bachelor's in neurobiology and neurosciences from Hunter College. And last but not least, we have Sara Massimo. She's a clinical research coordinator at Lenox Hill. She recently graduated from Rutgers master's degree program in biomedical science. She completed her bachelor's degree in biology at Syracuse. So welcome to all of you, and thank you for taking the time to speak with us this morning. The floor is all yours.
Thank you for that nice introduction. Faith, are you bringing up this?
Yeah, let me try. It's not working for Faith. I'll pull it up.
All right, let me see. I can see if I can do it also. Hold on one sec.
Let's see.
Let me know if you can't get it, and I can share my screen if it's...
Yeah, it's not working for me either.
All right, let me see. Hold on one sec. Let's see if I could just share this PowerPoint. What are you seeing now?
We can see it. Perfect.
Is it the whole thing?
Yep.
I think it's like block.
All right, can you see the whole thing now?
Yes. Yep.
Okay,
It's
perfect.
presentation mode.
All right, perfect. Hi, everyone. I'm Tamika. As Samantha said, I'm the Director of Clinical Research for Neurosurgery at Lenox Hill Hospital. Prior to me working at Lenox, I was working at Cornell as a research coordinator. And then about 10 years ago, me and Dr. Bokil, we came to Lenox Hill 10 years ago to set up our research program here. It's our 10-year anniversary. I don't know if you guys have heard about our gala, but we just had our big 10th anniversary gala celebrating all of our accomplishments that we've had over the years. And you'll see from our presentation that we've grown significantly. Again, Samantha introduced my team. We were also missing Juliana, who is our newest research assistant. And I don't know if you guys have heard from any of the Jenna's kids, but Juliana was a previous Jenna's kids who has now been hired as a research assistant before she goes to medical school. So like the previous talk, I just heard the end of it, but talking about mentorship and trajectory and paths, you grow. Juliana was there, and now she's here. So it's always good to grow and do other things. And then we have Olivia Albert. She's our research nurse practitioner, but she couldn't make it today. So from here, like when I first got to Lenox, there was probably just me and Sharice, who's our research nurse practitioner, and now we've grown to a significant team. Right now we have around 39 IRB approved studies. We have various types of study from interventional clinical trials, and those are the ones that patients are actually getting some kind of treatment. We have 6 tissue specimen collection studies, whether it's sponsor, which is basically we send it out, or it's something internal. We have a collaboration with Cold Spring Harbor, as you see down here, that we, in collaboration with the Northwell Health Biorepository, that we send tissue to Cold Spring Harbor. We have 4 registry studies. That's basically just collecting data. That's actually growing a lot more also just internally. We have a lot of fellows that have been starting registries. We have a new aneurysm, the one that we're starting. Humanitarian use device studies, and then kind of device feasibility studies that we've been approached recently to do a lot of these. We have kind of buckets of specialty trials. We have a big focus on neuro-oncology trials, which we'll see, we do glioblastoma, spine, which we're with Dr. Creedy coming on board. We have an increased amount of spine studies that we've been doing. Neuroendovascular with Dr. Cerulli starting. We have a new stroke study. We're starting a new e-shunt study, and his practice keeps growing with stroke. So we plan, we've always been really heavy with cancer and GBM, but obviously to become a really comprehensive neurosurgery research program, we have to kind of touch into these other areas. And then we have neuroplastics. I don't know if you heard from Dr. Ben Shalom yet, but we have a study with him using the longevity implant. And then Dr. Langer and some of the other guys, they're kind of really interested in device technology kind of studies. So that's kind of a hot topic that we've been working on now. Our enrollment, we enroll a lot of patients. Keep in mind, we have a rare disease. Most of our patients are glioblastoma. And so far this year, we've had 64 subjects total enroll on a clinical trial and 37 specifically in neuro-oncology. In 2023, we had 60 subjects for the whole year. So right now we're kind of halfway and we're kind of blowing our numbers out of the water. So trajectory, we plan on around having at least 100 patients enroll this year, which is amazing. Across Northwell Health, we're the highest enroller for cancer studies in our system. Some new studies that we're working on, I'm sure Dr. D'Amico's talked about his connectomics. We have a lot of kind of pockets of connectomic study that we've been doing. We have a new office-based ultrasound, blood-brain barrier disruption. I'll talk about that one later. A drug study for H3K27 mutation, an e-shunt study, that's a neuroendovascular study. SonoCloud, I'm not sure if we're talking about SonoCloud, but that's with Dr. D'Amico. It's basically an implant study for recurrent GBM. We just recently opened up our spine database, and then Dr. Caridi has a new study, spine study that we're working on. We do apply for a lot of grants. We get, thankfully, we get a lot of grants, and we have a lot of like notoriety in our community for research. All of our attendings and NPs, PAs, research, we're very involved with research. I think across our whole department, everyone kind of partakes in research in some capacity. Randy recently got a grant from Strong, and I think he recently got another one for doing a connectomics, a mentorship grant. Dr. Ben Shalom, he got the new Leadership Council Award, which gave us a grant that we got a new ultrasound machine for our neuroplastic studies. And last year, Dr. Bokil was awarded the Northwell Health Investigator of the Year Award. As I said before, we have a big collaboration with Cold Spring Harbor and Feinstein Institute. We do a lot of like bench to bedside kind of research. We send tissue. In the past, we've collaborated a lot with Feinstein. Our new blood-brain barrier disruption study, we've been working from a whole group of investigators at Feinstein, not specifically in GBM. Some of them do spleen, but we collaborate a lot with a lot of people. Some of our programs and events, not only do we do research, we have our brain, we do every other year, we do our brain tumor biotech summit. And then this year we had our big gala going forward. I'm not sure if we're going to doing summit gala, probably kind of a mix or two, but the Brain Tumor Biotech Summit basically is a summit where we have investigators, we have sponsors, biotech companies, researchers, patients all come into one room and kind of have a big discussion of what's the current state of research and neuro-oncology. We also do advances in neurotechnology. That's Dr. Ben Shalom's course that we do every year. We also have a Banbury brain tumor course we do. And some of our other programs I mentioned are Genis Kids that we talked about, that we have 3 basically fellows every year that are going into medical school the following year that we do. Obviously, then we have Brain Turns, which you guys are all here. And then we have our clinical research internship, which is my program that I do in partnership with the auxiliary. And it's for high school students basically to learn about clinical research and kind of get, basic knowledge of what kind of careers and what happens in clinical research. We have a big nonprofit collaboration. We work a lot with the ABTA, the Glioblastoma Research Organization, Strong, who gave Randy one of those grants. brain tumor companion, and Oligo Nation. It's really nice that we are very involved. Our patients are involved, so we always feel like we should support all of these nonprofit organizations as much as we can. Amber, who's the director of the glioblastoma research organization, she's doing basically brain tumor patient summit in Miami, so we'll be attending that. So I mean, we get involved with as much thing as we can, and also gives us a lot of exposure for our clinical trials. Next slide. Oh, it's me, right? All right. So for neuro-oncology trials, why we have such a big, we have a lot of enrollment, and we are able to consent a lot of people, is because basically, as you can see from this little diagram, we're able to enroll a patient at every point in their disease process. So we have our pre-diagnosis trial, we have our tissue collection, then we have our interventional trials, our FLAP study, and our IMPACT study, which Faith is going to talk about. Then prior to initiate, this is pre-diagnosis, then they have surgery. Then prior to initiating standard of care, these are some of our interventional trials that you can enroll in. This is our isatuximab, Avastin, Cantex. Our newly diagnosed, prior to initiating maintenance standard of care, this is after the 6 weeks of chemo RT, they can get onto Captem, Mimibex, or ONC201. And then after they complete that, if they recur, you're able to do our Omentum trial. And then after that, for recurrence, you have our Avastin trial again, isatuximab, Frontier, which I believe Sana is going to talk about, SonoCloud, and Respect. So basically, we are able to offer like this, our patients, even if a lot of patients also, they're not ready to enroll on a clinical trial, or they have other clinical trials and options that they're looking at. So if we always say like, hey, that's fine, no worries. Like if you want to do something else, if you're not ready, we always have a trial for you at some point. And this little chart are the national average for trial enrollment is around 5%. At Lenox Hill, around 60%. It's probably a little bit more. I think Faith did the calculations a little bit more. Around 60% of our patients enroll on a clinical trial at some point. So that's really good numbers compared to the national average. And our goal is to always provide the best care, the most innovative care for our patients. So our big portfolio for GBMs is focused a lot on blood-brain barrier disruption. I'm sure you guys know, obviously, glioblastoma is a very difficult disease to treat because your blood-brain barrier protects your brain, but when you have a brain tumor, obviously you want drugs to get in there. So you either have to get really small molecules, you have to get things to bypass the blood-brain barrier. And these are basically kind of pockets of what we do. So we have our intra-arterial delivery trials, which I mentioned. Then we have our surgical trials. That's our FLAP and our Omentum. And then we have our ultrasound trials, which is our SonoCloud. Oh, and then we also have our office-based. I missed that one. We have our we're in the process of writing a new protocol for office-based blood-brain barrier disruption for newly diagnosed GBM. So I just want to stress, for clinical research, we deal with so many people, and it's such it's a collaboration. It involves a lot of people. It's just not only us. It's just not the investigators, the PI doing the work. This is basically a diagram of everyone who we deal with. Lifeline of starting we are able to start studies pretty fast. We have probably a 2-month startup, but we are dealing with a lot of people, a lot of different departments, and we're just thankful for everybody who's at Lenox and at Northwell who's so committed to our success, and we honestly couldn't do it without everybody. So this is basically a diagram of what goes into clinical research and how involved it is. All right, I think Faith, Faith, one of our research coordinators.
Hi, can you guys hear me?
Yeah, I can hear you. She's going to give a little overview of our IMPACT study.
Okay.
Hi,
everyone.
Tell me when to do next slide.
Okay. I'm just going to do a brief overview of our MVAC study. So the official title for it is a randomized, multi-center, double-blinded, placebo-controlled phase 2b study to assess the safety and efficacy of IGV-001, an autologous cell immunotherapy with antisense oligonucleotide IMV-001 targeting IGF-1R in newly diagnosed patients with glioblastoma. The title is a really big of a mouthful, and it kind of just summarizes a big main points of it. But essentially, this study is done for patients who are newly diagnosed with a GBM. They haven't even had their confirmation of their diagnosis. So the confirmation usually happens when they're in surgery. Tissue is sent up while the doctor is doing the surgery. They send up a sample of the tissue to pathology, and pathology looks at it, and they determine from there whether or not it's a high-grade glioma on frozen. And so this study, patients are consented before we have that full confirmation. They just have an MRI scan that's indicative that they might have a high-grade glioma. So when patients undergo their craniotomy for their tumor resection, some of their tumor sample tissue is taken out and put aside to be able to be shipped off to this center. So once we have the confirmation that they're high-grade glioma, this tissue is then packaged and it's shipped to a manufacturing facility in Philadelphia. And there they prepare the tissues to make kind of a vaccine with it. So it's kind of a vaccine made out of their own tumor cells. And they create this compound and they put it into these biochambers. So they give us 20 biochambers. 10 of each are supposed to be implanted into, all 20 are supposed to be implanted into the patients. And then we receive them back 2 days after it's shipped out. And these biochambers are then implanted in the abdomen of patients, and it stays there for another 48 hours. So another 2 days, essentially. Patients will have the biochambers implanted in their abdomen. So there's 2 on each side in this study. And Tamika, can you go to the next slide, please? And this is just a quick video, just kind of showing the implantation and explantation process.
In order to solicit an immune response, the combined therapy chamber, IMV001, must be temporarily implanted in the body. For this procedure, the following tools will be required. Number 10 scalpel, cerebellar retractor, heavy tooth forceps for handling tissue, ADC thumb dressing forceps for handling the chamber, Metzenbaum scissors for dissection and fascial release, needle driver, and 2O bipolar sutures on a curved needle for all deep layer closures. 3O nylon on a curved needle for temporary skin closure, and 4O monocryl for permanent subcuticular skin closure after chamber explantation. At the time of removal of the tumor, an initial set of incisions, each 6 to 7 centimeters long, are made in each lower quadrant through the underlying fatty layers. Cerebellar retractors are then used to expose the rectus sheath. Then an incision is made into the rectus sheath, and blunt dissection creates space between rectus sheath and the underlying muscle for later placement of the chamber, typically a space of 7 by 7 centimeters square. Care should be taken not to dissect through the abdominal inscriptions. The rectus sheath and dermis are temporarily closed, and this is repeated until 2 implantation sites have been prepared on the patient's abdomen, each able to accommodate up to 10 chamber implants. Over the next 24 to 48 hours, the tumor samples are processed and the chambers are prepared for implantation. The chambers will arrive back to your site during the postoperative period, and IMVACs will provide advance notice of shipment so the surgical team can plan accordingly. Once the chambers have arrived after approximately 30 hours, the implantation procedure is initiated at bedside. The patient is sedated with conscious sedation technique, and the abdominal wounds are infiltrated with a local anesthetic, 0.5% bupivacaine. The temporary closing sutures are taken down with Metzenbaum scissors, and the incision and insertion pocket are reopened with forceps. Up to 10 chambers are placed in each pocket between the rectus sheath and the underlying muscle in each acceptor site. Reopening the rectus sheath may reveal that the rectus sheath opening may fall closer to one of the inscriptions relative to another, so there may be a shallow pocket on one side and a deeper pocket on the other side. It is recommended that a 2O bipolar tail be attached to the fenestrated flange of the first-in chambers that will be seated in the extremes of the deeper pocket. The tails should be neatly collected together out of the pocket and placed neatly to one side on the surface of the rectus sheath. These vicral tails will make the explant retrieval much easier. When all chambers are inserted, the rectus sheath is oversewn using figure-of-8 sutures. Care should be taken to elevate the leaves of the sheath to avoid puncturing any subjacent chambers. The dermis is again temporarily closed with a running 3/0 nylon suture, and the process is repeated to insert chambers in the other prepared implantation sites. 48 hours are allowed to pass as the immune system formulates its response to the implanted IMV-001 therapy. After the 48 hours, the same surgical protocol is executed with a sterile prep and drape, conscious sedation, and local anesthesia. The incisions are reopened with Metzenbaum scissors, and the chambers are extracted, and final closure is made in a 4-layer closure from the rectus sheath to the dermis with 2/0 vicryl. Skin closure is with a 4/0 monocryl subcuticular closure, and the wounds dressed with bacitracin ointment in a sterile dressing. Instrument, needle, and chamber counts are documented, and the patient recovered.
So that video is just a quick overview of how the implantation procedure is done. But essentially also this study is a randomized study. So it's randomized 2-to-1, so which means out of 3 patients, 2 patients will actually be getting the treatment. So they actually have biochambers that have their tumor material and it's mixed with the antibodies. And then 1 out of the 3 will just have a saline solution. But essentially all patients will have to still undergo the entire procedure and go through the whole thing. It's double blinded, so which means no one knows. The patient doesn't know. We don't know if anyone actually got it. So it's always a very interesting discussion with patients to be able to explain that to them as well when consenting them for this study, because obviously it's 2 extra procedures that they have to go through, which can be intense for patients sometimes. But a lot of patients just like the idea of being able to do something more. And there's a lot of steps too behind all of this. Like in the video, they mentioned that all of this needs to be documented, all documentation of all the biochambers. So there's a lot of documentation steps that we have to do as research coordinators to make sure that all the information is accounted for, to make sure that assessments are done, to make sure all the biochambers are there, they've arrived, they're in good condition, to make sure that everything goes smoothly for patients to have the procedure. And that's my quick summary on the impact study.
Thanks, Faith. Okay, now Sara Massimo, she's another one of our research coordinators. She's going to be talking about one of our new stroke studies.
Hi, everyone. I'll just start my video too for you guys. Hi, okay, so I'm going to be talking about one of our new stroke studies. The official title is a randomized placebo-controlled double-blind multi-center study of the safety and neuroprotective capacity of SCP-776 in subjects undergoing endovascular thrombectomy for acute ischemic stroke. So we'll be getting into what that title means exactly, and we'll break it down. So a little overview. The indication of this study is for anyone with an acute ischemic stroke. It's targeting the study population of patients who are actually undergoing an endovascular thrombectomy, which is a type of intervention that is used for acute ischemic stroke. The study drug that they're looking at is the SCP-776, and we'll look into what exactly that's made up of. It is a phase 2A and 2B. In part A of the study, the subjects will be given either placebo or one of 2 doses of the SCP-776. And then part B, they're going to take one of those doses from either cohort 1 or cohort 2 and match it against the placebo. It is randomized 1-to-1, which means there's a half and half chance they're going to be getting either the study drug or placebo. It's also double blinded like MBAC, so none of our research team, the investigator nor the patient will know what they're receiving. The only people who will know are our unblinded pharmacy team, who is in charge of getting the drug ready for us. So the study drug is SCP-776. Thanks, Weeks. It's a IGF-1 recombinant fusion protein. So it's an insulin-like growth factor and targets the insulin-like growth factor receptor that is present on dying cells. It's administered via an IV infusion, and during the study, we'll give them 2 doses, one either before or after the thrombectomy, and then 24 hours after the first dose. The hypothesis of the drug is they're hoping that it will inhibit cell damage, inhibit cell death and damage that's done to the cells after an acute ischemic stroke. So you'll see here the different components of it. We have the insulin-like growth factor that inhibits the cell death. We have a half-life extender that allows the drug to be present in the body for longer, and then an ANX-V arm, which binds to the dying cells. Next slide, please. So when we're looking for patients that we're recruiting, there's a set of inclusion and exclusion criteria that we screen the patients for to make sure that they're actually eligible to join the study. So these are just some of the main inclusion-exclusion criteria. Where they're having the acute ischemic stroke matters, how they were functioning prior to their stroke, whether they were living independently or not matters, and then the ranking of their stroke also matters. And then for some key exclusion criteria, there are certain drugs that are excluded. So if a patient is on an anticoagulant chronically, then they would be excluded. And if they received a thrombolytic therapy, either IV via intravenously or intra-arterially, they would also be excluded. Next slide, please. So this is just kind of a workflow of how we function when we get a stroke call. So we have a stroke team here that is dedicated to receiving those thrombectomy calls. And we are now kind of been merged with that team. So they know to notify us too if there's a potential patient for a thrombectomy. Will be called in as well, and we'll pre-screen them using that inclusion-exclusion that you just saw. They undergo different scans, so either CT or MRI to determine where the location of the stroke is as well. And then we have to go and consent the patient. Most of the time, these patients won't be able to consent to the trial themselves. So we'll look for an LAR, legally authorized representative, which is normally a family member who can consent on their behalf. Then we'll randomize them. They'll either receive placebo or the drug, and we give them the drug after or before thrombectomy, and then 24 hours after. And there's a bunch of study assessments too that we have to go through when a patient's on trial. And so that could be like vitals, physical exam, blood work, all of that. Next slide, please. And that's pretty much what the Arpeggio study is. Thank you.
Thanks, Sarah. And next, Sana is going to be talking about one of our trials for recurrent GBM. This fits into our portfolio for intra-arterial delivery. So Sana, take it away.
All right. Hi, everyone. So I'm going to be talking about the Frontier study, which is the feasibility study to evaluate the safety of the TheraSphere glioblastoma device in patients with recurrent GBM. The sponsor is Boston Scientific, and the PI is Dr. Bokil. Next slide, please. All right. So what is TheraSphere? So TheraSphere is an insoluble glass microsphere that contains the radioactive material yttrium-90. It's currently indicated and used for liver cancer, so hepatocellular carcinoma, and it basically is radiation. So it's the primary mechanism of action for the TheraSphere. And what we do in this trial is we inject the microspheres intra-arterially through a catheter placed in the feeding arteries. What that means is the endovascular surgeons find the artery through the groin that's providing blood to the tumor, and that's how they send these microspheres up to the tumor cavity. They penetrate and lodge within the microvasculature of the tumor, and then they exert local radiotherapeutic dose to the tumor, and then basically they leverage the blood supply to localize target radiation to that area. Next slide, please. So the mechanism of action for TheraSphere, it uses radiation to destroy the tumor. It's very high specific activity of the glass microspheres, which means there's less radiation administered to achieve the desired dose. And it creates a microembolic effect as a result. And it's a very selective delivery, which allows the radiation to exert its effect only to the tumor without harming the organs at risk. Next slide, please. Okay, and this is just a quick schematic of what the flow is like for this trial. And for every trial, and you've seen with what Faith and Sarah had discussed, we have an inclusion-exclusion criteria review where the research team, along with the doctors, review the medical history and eligibility, and we have some pre-procedure screening that we have to do with blood work and some assessments. And then we also have pre-procedure diagnostic imaging for this study. So there's the MRI and the CT, which assesses the baseline tumor characteristics, and it provides tumor segmentation. After that, we have the treatment planning. So there's two different parts to this study. We have a mapping procedure where we do the angiography and a cone beam CT to map and assess the neurovascular anatomy and the access to the feeding arteries. This is done by the neuroendovascular surgeons and other doctors involved, and it's used to determine the tumor volume. And with this specific mapping, they fuse the cone beam with the MRI to give them the best target volume to deliver the treatment. And then the overlay is performed, and then they do a 3D roadmap essentially to calculate the TheraSphere dose according to the volume that they see in the imaging. And all patients receive 40 gray, which is the unit of radiation, with plus or minus 10% window. Then the imaging guidance on the day of the procedure, the patient gets a repeated cone beam CT and an angiography, so they are under general anesthesia for this procedure. And this ensures that the catheter tip position enables the perfusion of the target vasculature, distribution, and treatment volume. So essentially what that means is that you're confirming what was done in the mapping procedure matches to what we're looking for in the actual delivery of these microspheres for the day of treatment. And then the doctors catheterize the target vessel, in which they use the 3D roadmap from the imaging, and then deliver the yttrium-90, the Y90 dose that they had calculated. Then we have the post-treatment delivery assessment. So this is one of the most important assessments post-treatment, is they do a Y90 PET and MRI. And this helps them see where the target volume of the yttrium-90 was exactly distributed, because the PET scan will light up the radioactivity, and it always has to be done within a very short time frame because the half-life of the yttrium-90 is very short, and it kind of starts dissipating within 45 minutes. So we have to get the patient in the PET scanner as soon as the procedure is completed. And follow-up visits include 1 week, 2 week, 3 weeks, and then monthly through 6 months, where we do the following assessments to ensure that the patient is doing okay. And then the MRI imaging is continued after the 6 months per the standard of care, which is every 2 months. The most important things that we look for in these visits is any limiting toxicity or any significant adverse events or any other adverse events that we need to document that may or may not be related to the procedure. Next slide, please. And this is just the inclusion criteria. I'm just going to go through some of the important ones, not all of them, but the most important inclusion criteria is that for this specific study, the volume of the tumor has to be in a non-eloquent area, which means that it can't be in an area that affects motor function. Because it is a phase 1 study, you're testing the safety and efficacy, and they have a very strict inclusion criteria, and that's one of the most important ones. And again, you have, specific ones like they should have had at least a performance status of greater than or less than or equal to 2, which is KPS of 70. So that's just their day-to-day function and how they are able to do their activities of daily living. And then there's some specifics with the blood work that we look for, and there's the ranges that we follow. And then there's also an angiographic mapping criteria. So I'd mentioned that there's 2 parts to this study. There's the angiographic mapping, where the patient does kind of a test imaging procedure to find the vasculature. And if in that time they find that it's not safe to go through a specific artery, there is no direct way to feed the tumor with these glass microbeads, you would be excluded from the study. Next slide, please. And this is the exclusion criteria. So again, if the patient meets any of these exclusions, then they are not able to be enrolled in the study. And some of the ones that we really look for is the location, again, of the disease, or if there's bilateral enhancing disease, or it's located in specific spheres of the brain. And they also exclude, radiosurgery, brachytherapy, hyperfractionated therapy. So when patients come to us, they have already undergone at recurrence a lot of treatments. So we have to go through their medical history and all of their results in a very thorough manner. And the whole research team, specifically our nurse practitioner Olivia, kind of makes sure that none of this exclusion criteria is met based on their clinical assessments, so that they can safely be enrolled in this study. And again, like the inclusion criteria, there's also an angiographic exclusion criteria. So if there's any significant vascular disease, or if there's feasible vascular access that goes through an eloquent area, then they will not be able to enroll in this study. And that's all I have for Frontier. Thank you for listening.
Thanks, Sana. That's pretty much our presentation. I don't know if anyone has any questions for us. I could also do a little ending if anybody, any questions? Then I just want to just end that a lot of people, like even when we're doing our clinical research internship right now, I just want to stress for everybody who's listening, like how many jobs there are in clinical research. There's what we do as a research coordinator, research assistant. We also have a dedicated research pharmacist. I also have my lawyers that look at our contracts, and then I have my finance team that does our budgets. We have lab, our PAs, NPs. So, when you're thinking about careers, just always think about, there's so many careers in clinical research, and, if anybody ever wants to reach out to us to have any thoughts and how they can get involved, please let us know.
So we actually do have some questions coming in. Christy and I have kind of been keeping an eye on that. So if you want, I can kind of just field those at you guys as we get them. So the first question that we have is, how powerful is the placebo effect in patients when undergoing these clinical trials?
We think it's very powerful. I mean, there's the placebo effect, and there's the Hawthorne effect that basically observe patients do better. I think with our team, you basically get like concierge care. So we're very involved. We're making your appointments. We're checking in on you multiple times, whether and we don't know either. So whether you're in the placebo group or you're in the treatment group, you're seeing us every week, every month, calling from us, getting emails. So I think it's definitely, we think obviously based on MRI scan, you'll see differences, depending on what study they're on. But yeah, when they're on a trial, like they, a lot of patients think they're getting it no matter what, because the care that they're getting is also so good. I don't know if anybody else wants to add anything to that on my team.
Yeah, I think I agree with Tamika. We have a very robust workflow for everything that we do, and we kind of all communicate and work together really well.
Awesome. Thank you so much. So the next question that we have, what experiences or steps did you guys take to become research coordinators?
So I'll just do a quick overview. So I did, as Samantha said, I did my master's in public health at NYU. During that time, I was working at the Children's Brain Tumor Foundation while I was doing my master's. And then when I was finishing my master's in public health, I kind of was like, oh, like, what's my next step? And Dr. Swadan, who was one of the pediatric neurosurgeons at Cornell, he was on our board, and he was basically like, hey, like, you should be a research coordinator, like, you're great, you know a little bit about brain stuff, so I started working there, and I kind of just like, that was it. I mean, I've told everybody sometimes, like, I've tried to get out and do like other, like, not specifically neurosurgery, but at the end of the day, I really love what I do. I've been doing it for 13 years, so I think it's a great career path, and sometimes a career kind of picks you, not you pick it, and it's been a good ride for me. Anybody else want to talk about their journey?
Yeah, I can chime in a little bit. So I was a dosimetrist back in Australia, and I dabbled into a little bit of research for prostate and breast cancer. And it was very interesting to me how the trials were, because I thought research was so lab based. I thought it was just, you sit by yourself and work under the microscope. But there was so much more to it once I started to go through some of these trials. And that's what motivated me to move to New York. And then coming here and working through a very big portfolio of trials has been really exciting. And I think, it doesn't matter if you don't necessarily have a research background to be interested in the research career. You have different ways of getting there, and kind of getting the experience and making it into a full career.
Awesome, thank you. So kind of similar to what you were just saying, this is for IMGs, and if there are any opportunities or any advice that you guys have to do research in neurosurgery before applying to residency.
It all depends. We have had different people come and shadow us, whether before residency. I think it all depends on what you're doing. I think everybody, there's a role for, if you really, we've had people come and because they love research and they know their career path is in research, and they've worked with us, whether it's been like fellowship or like Juliana, who's going to medical school next year. So I think it's very, like, you could also always like kind of create your own path, depending, obviously, to some extent. But I think if you love research, you should definitely try and get into research as soon as possible. I think it's very beneficial. Like, I have like, when a lot of like residents, fellows, they've never been a protocol research, anything like that. So the sooner you want to get into it, I mean, I think more than anything, research is what's going to changes the game in medicine. Rather, yes, obviously there's surgical, there's technology and everything, but research is not going away, and innovation's never going away.
Absolutely, thank you. Someone asked, how important are double blinds and how does this method complicate trials?
Yeah, so double blind study is basically like the gold standard for research. So when you go to the FDA, we have a lot of investigator initiated studies. We go to the FDA, and this is basically the gold standard. They want double blinded randomized control studies. Yes, you can do, and we struggle this, especially because we deal with such a bad disease. We struggle with this of having people get randomized to standard of care, because for us, we're like, hey, like, we want everyone to get the best treatment. If we think this is the best treatment, they get it. But then obviously, then me, the science person in me and the research in me, obviously says, like, hey, well, we need data. As much as we can talk about this anecdotally, like, hey, yeah, they do better, they do worse, like, I think that's why we have randomized double blinded control studies, because we need to see that data. And there's so many variables when you start looking at other things that contribute to the success of a clinical trial. So as much as I mean, me, Dr. Bookvar, everybody, like, we would love to put every patient on a trial and get randomized to treatment, but the data science person in me says this is what the FDA wants. This is what we need. I think to really prove that, hey, this is superior to the standard of care, we need them.
Great, thank you so much. The next question for you guys, how could clinical research interfere with treatment and how is this addressed?
So in clinical trials on glioblastoma, a lot of the trials are, or not even a lot of the trials, they try and go along as much as standard of care as possible. So that you will do something in addition to standard of care. So for example, our GBM studies, a lot of our trials say, hey, like you'll still be getting your standard of care chemo RT, but you'll be getting like an extra intra-arterial Avastin dose. There are some Sarah has a trial for Cantex. It's a drug aziliragon, and that targets patients who are MGMT unmethylated. That replaces the standard of care Temodar because Temodar targets MGMT, and if they don't have the MGMT methylation, they don't do as well. So in that trial, it's like, hey, well, they're probably not going to respond to Temodar, so why don't we give them the aziliragon? So that's one trial that they do replace the standard of care, but most of the times they try as much to, like, in addition to standard of care. When you go into the recurrence and you kind of go to other trials, a lot of the trials there's basically like 5 approved therapies for glioblastoma, so there's not a lot of options. So once you get out of those like 5 approved standard of care, that's all you have is clinical trials. So as much as we hardly have any patients that say like, oh, hey, like a lot of them have exhausted their standard of care options, so they have to kind of resort to clinical trials.
Absolutely, thank you. Someone asked what advice you would give to medical students that want to pursue research but don't have any background and don't know where to start.
I honestly, a lot of our students, even Sana, Faith, Sarah, none of them really had a research background. If you find somebody like you guys talked about the previous previous talk about mentorship, if you find a good mentor that's willing to help you, obviously people are busy, but I think if you get in early, as I said before, and kind of form a relationship with someone in research, whether it's an investigator or someone like me, or even, and there's a lot of people that do research. It's just not only like, surgeons are busy, but you can form and develop relationships that you can get into research. Obviously, I'm not a clinical person, but I do all the and in research, that's why I teach everybody, you should know everything about research. You should know about regulatory. You should know about IRB. You shouldn't just know, oh, hey, I'm going to go see a patient. Like that's a very, very small part of research is seeing the patients. The startup takes a really long time, and then budget, contract, IRBs, there's tons of approvals. So I think once you know just even the basics of research, there's also a couple courses you can always do. Like there's always city courses and different things. But I would just recommend to try and find somebody that's willing to kind of, form a relationship with you and kind of teach you about research, even if it's not an actual clinical provider teaching it, because there's a lot of different things in research that happen before we get to the patient phase.
Definitely, thank you. Someone asked in regards to the last research method explained with the spheres, how come patients with a tumor in the forebrain are unable to participate in this trial?
You want me to answer, Sana?
I can answer. Sorry, can you repeat the question? I didn't hear it.
Yeah,
Sorry.
absolutely. In regards to the last research method explained with the spheres, how come
Yep.
patients with a tumor in the forebrain are unable to participate in this trial?
Yeah, because it's a phase 1 study and it's testing safety and efficacy, they want to make sure that it's not going to affect motor function. So their first and foremost, endpoint is the efficacy and safety on the phase 1 trial. So they don't want to, give the microbeads with radiation into an area that's going to severely impact the quality of life for a patient and have them not able to function at all. That is not kind of the endpoint of this phase 1 study. So once they deem that it's safe to deliver this dose in the non-eloquent area, then they'll start exploring other parts of the brain as well. To me, guys, anything else you wanted to add?
Nope, that's it.
Yeah.
Awesome, thank you. We have a question asking when an experimental drug or treatment protocol is supposed to be an improvement over something that already works, are people in the control group given a placebo, or are they given the existing standard of care?
Um, so what are they asking if there's something that's already approved that's superior to?
They're asking, so if something that you're testing out in your trial is supposed to be better than what is currently the standard of care, is the placebo group given a placebo, or are they given the current standard of care?
Well, it's so for the like any clinical trial, you have to follow protocols and what the FDA wants you to do. Unless that is an approved treatment, you're not you're sticking to the protocol. If you are in a trial and it says, "Hey, you're randomized to this, you're randomized to this," we don't know that until it gets FDA approval. So you have phase 1, you have phase 2, you have phase 3, you have post-market, you have FDA post-market approval, and that's when it goes to market. Only until when it goes to market, that's when you can pick and choose what kind of treatments you want. Other than that, if you're still in a trial or if it's still not FDA approved officially, you can't, that's it. Like there's standard NCI guidelines for every disease of what you should and should not be giving.
Right. Okay, thank you. Someone says that Dr. D'Amico was discussing the molecular and cellular aspect of research in creating treatments for GBM and other cancers. Are there people in your department working on that, and is it a possible career?
Yeah, so we work a lot as I earlier Cold Spring Harbor. So Cold Spring Harbor, Dr. Aaliyah Mills, she's at Cold Spring Harbor and she basically looks at molecular components of glioblastoma in mice. She just had a Nature paper published. I think it's what is it BRD8? What is it?
BRD8.
BRD8. So they're looking at that. And then, yeah, that's our goal. That's like even that Banbury course that I spoke about. That's basically when we go to Cold Spring Harbor and we kind of have these discussions because there's a lot of disconnect from, the bench research to what we do, so with these, with collaborating and communicating with all these people, they see what they see, but they're very like molecular. What we see is like actual patients, actually MRI scans on people. So yes, it's definitely an opportunity. We send tissue to Cold Spring Harbor. We're actually doing a case on Tuesday. And with our tumor tissue, they do they build what are the organoids. They're building organoids with our tumor tissue at Cold Spring Harbor.
Very cool. Thank you. Someone asked what logistical issues you faced throughout clinical trials.
Well, I mean, a lot of issues. I mean, when I first got to Lenox Hill wasn't really like a research, it wasn't really a research place, so I think there was a big learning curve, especially coming from Cornell, which has like a more established research. So, even I remember one of my first studies, we were trying to bring a virus in the OR, and it was like the end of the world for a lot of people because they were like, no, this is like, they've never seen it before. So it's like doing in-services, talking to the OR, talking to administration. There's a lot of hula hoops that could happen. I mean, you have budget problems. You have like hey, we don't have a centrifuge. I mean, that's why we do like a bunch of feasibility for clinical trials. For each study, we basically do a feasibility questionnaire and we say, hey, like, is this actual feasible? Do we have the sometimes we don't have the patient population. Sometimes just resources. There's so many things that could happen. That's why you do a feasibility, because also clinical research, it's a lot of time and it's a lot of money. So you don't want to waste any time or money that if you're not going to enroll patients. I've had patients like that virus trial. It was a phase 1 trial. We did all this work. It was like awful. And then it finally got approved. It got open and the study closed. So, it was a phase 1 study, and phase 1s, they go fast because they only have a limited amount. Like they have 10 patients. So if you don't get up and running fast, another site is going to take your spot, and then all the spots are getting taken up and then it's closed. So there's tons of hurdles in clinical research, especially I think for research, you're not only, it's not like an isolated like situation. You're dealing with so many people, you're dealing with so many approvals. So I mean, IT can be an issue. Even getting an app on an iPad is an issue because you have to ask mobile device management to do it. So there's like, and there's a lot of IT security. So there's tons of things in research that happen. But I think that's why I feel like if you're able to troubleshoot really well and kind of just like every day is a new day, I feel like you would love clinical research because every day is a new day. We don't know what's going to happen. Like obviously we have kind of a set schedule, but there's a lot of things that go on during the day that we have to deal with, and we kind of have to put out fires like ongoing, depending on what's happening.
Absolutely. Thank you so much. Someone asked that when you talk about treatments like TheraSphere and IGV-001, are these mostly developed in Lenox Hill, or do you often collaborate with other companies and research institutions to test their innovations?
So both of those are sponsored studies. So one, the MVAX, there's the MVAX study, that's the Chambers, and then the Frontier studies with Boston Scientific. So yeah, we do a lot of investigator-initiated studies, but then we have a lot of sponsor-initiated study where they basically come to us and say like, hey, like you have so much experience in intra-arterial delivery, you have so much experience with glioblastoma and research, like you have great data. And that's another thing about people ask us to do their studies because we have such good data. We're good communicators, and we have a history of doing a lot of research. So I mean, like our stroke study. So our stroke stuff is kind of getting ramped up, but once you become a big comprehensive stroke center, that's when you get all the trials. So right now we get a lot of the trials, and that's why we have so much. We have probably the most in New York City, and probably in a lot of places. I mean, I don't know how many of the, but most, we have a lot. We have a lot of sponsors that come directly to us because we have such a good history of running clinical trials.
Absolutely. That's so cool. Thank you. Maybe we do one more question and then wrap up for the morning. Someone asked, how are the long-term effects of experimental treatments assessed?
So you could, most of our trials, you're looking at their response criteria. So we're looking at MRIs. So for glioblastoma. So for like you're basically looking, is your tumor getting worse? It's called the Raynaud criteria. So it's basically like, are you having a complete response, a partial response, stable, or if you have disease progression. So basically, if you have disease progression, that's meaning the treatment's not working. So for glioblastoma, that's how we kind of assess. But then you have other trials that assess, differently. Your stroke study, you're looking at like stroke scale studies. You're looking at, physical and neuro exams kind of thing. So it all depends on what you're looking at. But for glioblastoma, you're looking at the response. And obviously we have labs that you take, but most of it is the response. And then, so it's your overall survival and your progression-free survival. So your progression-free survival is if you're progressing or not. And then your overall survival is basically like how long you're living. So those are the two big main components that you'll see for GBM studies.
Awesome. Thank you so much. Thank you, all of you, for taking the time to talk to our brain turns this morning. Brain turns, if we could say thank you to all of our wonderful speakers in the chat, that would be great. And I hope you guys all have a great day. And thank you again.
Thank you, everyone.
Thank you.
I'm going to put up tomorrow's schedule just for a little overview of what we have going on tomorrow. So first up tomorrow, we have a virtual spine OR with Dr. Gilad. So that'll be super. Am I pronouncing that right? Gilad? Okay,
Yes,
cool.
Monique Gilad.
That'll be super fun. And then at 10 a.m., we have nursing and neurosurgery to learn, obviously, about the nurses and what they do to help the neurosurgeons and their part in the medical field. And then we have neurosurgical residency. I know a lot of you guys have questions about residency after medical school, so you'll be able to ask our resident panel any questions that you might have. I'll leave this up for another minute or so. Hannah, Christy, if you guys have anything to add. Make sure to vote for the
Yes.
t-shirts
I
on
was
the
about to
Instagram.
say, make sure you cast your vote for your pick for our summer 2024 swag. It'll be featured on, or the winning design will be featured on our bonfire merchandise shop, and all of the profits from those t-shirts, they go towards funding our Zoom licensing and our other free educational programs at Lenox Hill Neurosurgery. So it's a great way to commemorate your experience and also to support the future students who can benefit from this type of programming.
is 12 o'clock. So we will see all of you guys tomorrow for another, and tomorrow's our second to last day. That's so
I
sad.
know.
Another great day.
Yes, if you guys have questions, I know I've been getting some questions about the certificates. Don't worry, we will send you the link to download your certificate on Friday. We're gonna send the link via email. We'll also post it in the chat during the Zoom. So you guys will get the link to download your certificate of completion, I promise.
Thank you, everyone.
All right, thanks, Samantha. Thanks, Christy.
Of
Thank
course.
you,
thank
Hannah.
See you tomorrow.
Bye.
Bye.